were a little bit more effective. So mom may already be in labor, but maybe her contractions are starting to space out a little bit, or they're not as strong as they could be. We can give, do things and give medications to augment her labor to make it more effective. Okay. Prior to an induction, we want to make sure that the baby's lungs are mature. And if you remember back to chapter 5, we talked about the LS ratio, right? Mm-hmm. The LS ratio is the lecithin sphingomyelin ratio. That tells us fetal lung maturity, if the baby's lungs are mature. So they'll do an amniocentesis and take a sample of amniotic fluid and check the LS ratio before electing to induce somebody who is preterm. Okay, if they're 39 weeks and beyond, then that's fine. You don't have to check lung maturity. But before that, they'll check to see if the lungs are mature. The Bishop score, this is kind of a nice to know. You may see it in like ATI somewhere, but I won't ask you about it. The Bishop score is used to evaluate the cervix. Did you get one of these channels? Yeah. I have some extras. The Bishop score evaluates the cervix and determines whether or not the cervix is ready for an induction. Okay, we want some of those pre-cervical changes to be happening in order to, hopefully have a successful induction and delivery. Okay, so they'll look at things with the position of the cervix, the consistency, if there's any effacement or dilation happening before the induction, and then also fetal station. Okay, again, you don't have to know this, kind of a nice to know. You can't just, throw somebody in the hospital, give them Pitocin, and hope for the best. There's lots of things that come into play. All right, indications for an induction. When can we induce labor? What would be a reason? These are all reasons that we can induce labor. Somebody has gestational hypertension, their blood pressure is high. So, delivery is a cure for hypertension, right? Getting that baby out. Ruptured membranes without labor. If your water breaks and you're not in labor, we have to induce. An infection within the uterus. Medical problems in the mom. She has uncontrolled diabetes, pulmonary disease, anything that's could be a risk or a threat to her life, that would be a good reason for an induction. Fetal problems, okay, slow growth, prolonged pregnancy, incompatibility with mom and baby blood types is a reason for an induction. Placental insufficiency, if the placenta is not working, then it's better to take the baby out and let the baby grow on the outside, which also goes along with slow growth, right? They're not growing because the placenta is probably not giving them what they need. Abnormal labor progress and fetal death. The convenience for the provider or the family is not an indication for an induction. Okay, like, I want to have my baby on this day.
20 years ago it was.
Yes, it was.
5 years ago it was.
And not even 15, 20 years ago.
3 days, yeah, my daughter's 19, I was like 3 days overdue, and they're like, okay, let's get this baby out.
Yeah. Oh, as soon as you get to 40 weeks, they're like, oh, when do you want to take the induce? Like,
Exactly.
They would love to take the baby out because we'll talk a little bit about prolonged pregnancy in this chapter, and then again, I think in chapter 13. There are some things that can occur with going beyond the due date too. That could be, put the baby at risk. So there could be special scenarios if it's somebody who has a history of very fast births. They may say like, well, why don't we just do an induction so that we can have you here in the hospital and not on the side of the highway when the baby's born. So those would be special scenarios, but we don't just say. And with an induction too, there's a good chance this is not going to happen in a couple hours. It's going to be at least 24, could be days that an induction lasts. So picking because you want a certain provider is probably not going to help because you're probably not going to deliver that day. Contraindications to an induction. Who don't we induce? Anybody who shouldn't have vaginal delivery anyway. Okay. If you have a placenta previa, cord prolapse, if the baby's breech, if the baby's very high up in the uterus, not a good candidate for an induction. Active herpes infection, previous classical or vertical C-section. We'll look at C-sections in this chapter. You can attempt to induce a preterm pregnancy if the benefits outweigh the risk. It's better to have a baby out than in. Then we will deliver prematurely. All right, so some non-pharmacological methods to stimulate contractions. What can we do without involving medications to get labor jump-started? Huh? What did you say?
I said sex.
Yes. Yes.
So wrong.
We'll jump right to that one. Intercourse. That's Tyshell Scotia.
I don't have kids yet. That's what we know how I'm starting my labor.
It does work, okay, with intercourse, we'll do that one first. Orgasms can stimulate a contraction, and also sperm contains prostaglandins, and I think it's on the next slide. Prostaglandins help soften the cervix, so they actually, you know, they help put the baby in and they help put the baby out. Those little swimmers.
Those little swimmers.
Walking can help, and walking helps also, you know, with some pelvic motions that can help facilitate fetal descent. There's a new thing like curb walking. Have you guys seen like any Instagrammers doing that? Or they like walk like one up on a curb.
Yeah.
And then they do the other side.
I used to walk in the squat.
Walk and squat.
Yeah.
Lunge, like
And then
lunges.
okra.
Nipple
Slide
stimulation
up.
works, so moms can use a pump if they want for that. That releases oxytocin, and oxytocin helps the uterus contract. So this can also be used to help kickstart a labor that's stalled. If labor and the contractions start to space out or die down, can bring her in a breast pump. She's in labor, points of heat, so go, and then go flash sometimes, depending on with any of these contractions come to then and stop the stimulation. Leads to a face that services or they like to use it. I mean, this occurs naturally in most women. You can't just put it in the hospital, throw some up, and hope for the best. If the cervix is not ripe or soft, it's not going to go well. Okay, so somebody who doesn't have a soft cervix already, then medication can be given just as looks like a crochet hook. And kind of nick the sac to release the fluid. With spontaneous rupture of the bridge. So anytime the water breaks, whether for you or on its own, cord prolapse is one of the concerns. Okay, did we talk about cord prolapse a little bit? Spaghetti in the sink. We referenced it. Okay, so that cord can prolapse down through the opening of the cervix with that big gush. Infection. They're no longer in their little protective bubble. Okay, so the sooner the baby's born after the water breaks, the better. The longer they stay in there, the higher the risk for infection. Usually they like to get them delivered within 24 hours. Now, if you're at the 24-hour mark and you're 9 centimeters, then you're like, time's up, like, they'll let you keep going. But if you're 9 centimeters, or if you're at the 24-hour mark and you're only 2, then they may opt to do a C-section, depending on what else is going on. And then an abruption. We learned about an abruption, I think, in chapter 5, right? An abruption is when the placenta separates prematurely from the wall of the uterus. So when you have your uterus is nice and inflated and full of amniotic fluid and the placenta is attached nicely, when that water breaks, it's like letting a little bit of air out of the balloon, right? And that could cause some separation of the placenta from the wall. Not common, but it can happen. Nursing care after water breaks, baby's heart rate. 1 full minute of fetal heart rate. Right? Because our biggest concern of all of those things is cord prolapse. Right? Yes, infections are concerned, but you don't get an infection right away. It takes time. So we want to make sure that the cord has a prolapse and the baby's heart rate is okay. Color, odor, amount, that's all kind of simultaneously looked at while we're monitoring the baby's heart rate. Mom's temperature, once her water's broken, we're gonna do more frequent temperature monitoring, right? Because she's at higher risk of infection. When anything over 38 suggests infection. If the amniotic fluid is green, the baby's probably in their house, which usually indicates that they're stressed. It can increase complications of their as well for something called meconium aspiration. Okay, oxytocin induction or augmentation. So once the cervix is favorable or ripe, then oxytocin is given. There is no one-size-fits-all dose. I start with a small dose and kind of go from there. See how the woman tolerates it, how her body responds to it. You can titrate it up and down depending on the response of mom and also the baby. Right? If mom's getting oxytocin and the baby's having a lot of decelerations in their heart rate, they're telling you, I don't like this. This is too much. Gotta back off. Oxytocin is also used after the baby's born to help that uterus stay nice and contracted. Okay, so we can have the placental site healed and clamp off all of those little bleeding vessels. Complications of an augmentation. Most common complications are fetal compromise and uterine rupture. Excessive contractions leads to reduced flow through the placenta, which can compromise the baby. Oxytocin is discontinued or the rate is reduced if there's any sign that the baby's not tolerating it, or if there's excessive uterine contractions. If the uterus is too contracted or the contractions are happening too close together, then a medication can be given to completely stop those contractions from happening. Those are called procolytics, and we'll talk about those later in this chapter. Nursing care, baseline vitals, of course, and fetal monitoring, so we can see what everybody's baseline is before we start any augmentation or induction. And if there's any abnormalities, then stop the oxytocin. An amnio infusion is putting fluid back into the uterus for a baby that may be having a lot of variable decelerations. Variable decelerations are usually related to cord prolapse, right, according to our veal chop. So cord prolapse or cord compression, not prolapse, cord compression. So if the cord is being compressed or squished, then putting some fluid back in can help reduce the number of variable decelerations the baby's having. They can also put fluid back in to dilute meconium-stained amniotic fluid. Okay. If the baby has meconium in utero, putting some fluid in can kind of help wash some of it out or dilute it so that if the baby does inhale it, it's not as caustic to the lungs. Okay, but the fluid's not necessarily going to stay in there, so it's gonna come out. So we have to document the color, odor, and amount of any fluid expelled. It's not that common to do an amnio infusion. All right, aversion is the method of changing the fetal position. Flipping the baby. Two methods. External is usually performed at 37 weeks, but before the onset of labor, or internal, which is an emergency and it's during labor. More often, the second delivery and the twin delivery. Not indicated for any woman that shouldn't have a vaginal delivery. Is there any reason to take a baby that's breech and try and flip that baby head down if the mom has had three previous C-sections? No. There's no point in doing that. Or if the baby's breech and the mom has placenta previa, there's no point. She's got to have a C-section anyway, so it doesn't matter what position the baby's facing. Risks and contraindications to aversion. Disproportion between the mom's pelvic size and fetal size. If the mom's pelvis is very small and the baby is very large, maybe that baby's gonna be too big. Abnormal uterine or pelvic size or shape, abnormal placental placement, previous C-sections, active herpes infection, inadequate amniotic fluid, poor placental function. If the placenta is not functioning well, the baby's not going to tolerate being pushed around, literally. Multi-fetal gestation, there's more than one baby in there, they're going to get all tangled up in each other, so you can't flip them around. And the concern is that the baby's just going to get tangled up in their cord. Okay, so before aversion, we're going to get a non-stress test to make sure the baby is happy in utero. They will give a tocolytic drug. Tocolytics relax the uterus, so you don't want the uterus fighting against you with little tiny Braxton Hicks contractions. So tocolytic will completely relax the uterus. They use an ultrasound to kind of guide the procedure. And what they try and do is take the baby that is breech and kind of push the baby up out of the mom's pelvis as they're pushing down on the head, and they try and get the baby to just do a somersault.
Oh, Jesus.
It's a lot of pushing.
They did that to me.
They did that to who?
My mom.
To your mom?
In labor with me.
During labor?
I changed positions at the last minute.
Troublemaker.
Yes.
So they try and get the baby to do a somersault and go head down. Because we're doing so much manipulation and pushing so hard, if a mom is Rh negative, she should get Roban, because we don't know if there's any small little vessels that may have torn. The real kick in the butt is that you could get that baby head down, and the next day the baby would be like, I like it better this way, and just flip right back.
That was comfortable the other day.
Flip right back to the way that they're used to. So, you know, it's not, you don't have to do this. If your baby's breech, you don't have to have aversion. You can opt to just have a C-section if
They
you
did
want.
that anyway.
Yes.
Yeah. And she has the vertical cut instead of horizontal. so she's
Oh,
not
really?
Too high up.
Oh my gosh, you really are telling me here.
Very exciting.
So yeah, it's just an option for somebody who wants to try and have a vaginal delivery and the baby's not cooperating.
I'm still
Okay.
operating.
An episiotomy. Episiotomy and laceration. Episiotomy is a surgical enlargement of the vaginal opening during birth. Why would they do an episiotomy? Better control over where and how much of the vaginal opening is enlarged, and an opening with a clean edge rather than a ragged opening of a tear. It used to be everybody got an episiotomy. Now, like, they don't do it unless they need to. Lots of perineal massage and stretching exercises can help. They use like mineral oil to help stretch the tissue before the baby's headed out, so that we can hopefully prevent any tearing from happening. An episiotomy is very similar, only it happens on its own, so it's an uncontrolled tear. They vary by degree, classified by the amount of tissue involved. So first degree may be superficial vaginal mucosa or perineal skin, all the way to a fourth degree, which extends through the anal sphincter into the rectal mucosa. You do not want that. You don't want it. So, you know, if it looks like somebody might end up with a laceration, is it better to do an episiotomy or just let the laceration happen? You know, that's the toss-up in that situation. You know, the episiotomy, this is not a great comparison, but if you take a piece of paper and you cut it, and you take a piece of paper and you rip it, and you want to tape it back together, which one looks better?
Yeah.
The cut, right? So that's, you know, the toss-up. If somebody looks like they're going to have a laceration, if that skin is stretching or that tissue is stretching, is it better to just do the episiotomy? Because then it leads to straight edge and an easier repair and easier healing. Okay, infection is the primary concern. It's a break in tissue that's been repaired. There is the additional risk that they do an episiotomy and you still have a laceration beyond that, where you tear further. Nursing care begins during that 4th stage of labor. Ice packs, ice. Give that mama some ice. Okay, ice will help with swelling, edema, bruising, pain. After the first 12 to 24 hours, heat helps. Heat promotes healing. It promotes circulation of the area, increases blood flow. So sits, backs, heating pads, things like that. Mild analgesics. Motrin should be just fine. That's what they say. All right, we'll do forceps and vacuum and then stop. But I don't want to leave you with these lacerations here before dinner. Forceps and vacuum extraction. So forceps provide traction and rotation to the fetal head when the mom's pushing efforts are insufficient. They look like salad tongs, kind of. They have curved blades. They fit around the baby's head without compressing it. Okay. They are useful also for breech deliveries to help deliver the baby's head if needed. The vacuum uses suction applied to the baby's head. With both of these, you know, the baby's not being pulled out, okay? When the baby is being delivered, every time mom pushes, that head comes out a little bit, and then in between pushes, may rock back up a little bit. She pushes again, more of the head, back up. The baby kind of rocks its head all the way down until it's delivered. So with forceps and a vacuum, when mom pushes, they can keep that head there so that the next push, you know, keeps the baby's head from kind of retracting back up too much. The vacuum can only be used with the baby's head down, obviously. It needs something to suction onto. And the nice thing with the vacuum is that it doesn't take up any extra space in mom's pelvis, right? Forceps have to go around the baby's head, where the vacuum can just sit on top. Okay, so here's some images here. So those forceps go around the baby's head, and the vacuum's going to sit on top. Like a plunger. Yeah. These may be used to end the 2nd stage of labor if it's in the best interest of the mom or the baby. Maybe mom is tired. She may not be pushing effectively anymore. It's just a way to help her finish the job. If she has cardiac or pulmonary disorders, they may use this because they don't want to put too much strain on her heart and lungs. So they may automatically use vacuum or forceps to help with her pushing stage. It is not a substitute for a C-section. Okay. So if the baby needs to come out, we don't say, oh, let me go get the vacuum. Like if it's an emergency, the baby's got to come out. Okay, you can't just try and use that, either a vacuum or forceps. Risks for baby and mom, trauma to maternal or fetal tissues. Mom may have a laceration or a hematoma. The infant can have bruising, facial or scalp lacerations, a cephalic hematoma or an intracranial hemorrhage. The vacuum will cause a harmless area of circular edema called a signon, like this. Okay. Their skin is very tender and sensitive and thin. So, you know, if you take the hose to a vacuum cleaner and stick it on your arm and leave it there, you take it off, it's going to be a red bump, right, from the suction. So the same thing's going to happen to the baby's head, that their skin is so sensitive, sometimes it looks kind of raw, but it goes away pretty quickly. This baby's got forceps marks here and a little bit of bruising. That will also go away. Nursing care, we want to examine the infant's head for lacerations, abrasions, or bruising. Facial reddening and molding is common. We don't use ice packs on the baby's heads, right, or anywhere on the baby. Pressure from the forceps can injure the baby's facial nerve. So this is where it's important to, when you're looking at that baby after they're born, after they've had forceps applied, make sure their face is moving symmetrically. You have a question?
My niece, she was removed that way, and she got a cut near her eye. So like it was scary because as soon as they got the forceps, it became like a surgical thing. So all of the surgical team came in
Yeah,
and they had to fix to see if like it did something to her eye, but it was fine. It was just like
Just an
outside,
abrasion?
on the side, yeah.
well, that's good. It can cause damage to the nerve just
Just fell
because.
out.
Oh.
Like he
So
put it in
not,
and it came
there's,
slide out.
I think there's probably 2 providers that I know of left that use forceps still. Everybody uses a vacuum. It's more user friendly. The new ones coming in, and if that's what they're using, then that's what they're training on. So there's probably a handful in this area that still even use forceps. The vacuum is so much easier.
It was an older guy.
Yeah, yeah.
He was like the only one there that could do it.
Yep.
The vacuum was.
Yeah. Yeah. They can have some nerve damage in their face. It goes away, it heals on its own. We should make sure we make a note if they have like thing on the side of their face. That's a good place to stop. We will finish with C-sections tomorrow and everything else. Any questions? No? Alrighty, enjoy your dinner. What do you have after? Cardiac or solo cardiac?
Yes.
I can't keep track of the life skills, so.
We sit up.
I did the schedule too, and I can't keep track of that stuff.
I'm